So our next speaker is my friend and colleague, Dr. Viviana Benitez, who's my co-physician leader of the NF program within neurology at Boston Children's. And she is going to give us some updates on MEK inhibitors for NF1, kind of elaborating on what you heard a little bit earlier this morning and more information that's hot off the press regarding new studies and more recent FDA approvals.
Thank you, Nikki. Hi, everyone. My name is Viviana Benitez. I'm one of the neurologists over at the NF program at Boston Children's and Dana-Farber. And I'm, was happy to hear people had questions about this because this is a topic I'll talk about, MEK inhibitors and their use in some of the more common tumors that we see related to NF1. So I just wanted to break down what I'm going to be talking about. I'll give a little bit of background on MEK inhibitors, and then I'll focus specifically first on plexiform neurofibromas in NF1 and the use of MEK inhibitors for treatment of those tumors, and then low-grade gliomas in NF1 and the use of MEK inhibitors for those. And I have a little summary table that I'll allude to initially and then kind of wrap back as to the different MEK inhibitors and where they are in studies and approvals. So you've seen this pathway now a couple of times. This is a pathway related to how NF1 affects cell growth and creates these tumors. So we talked about there's a protein that the NF1 gene produces, this neurofibromin, and that takes the active GTP-bound RAS into the inactive GDP-bound RAS. And that's kind of a checkpoint that prevents this unchecked cell growth and tumor creation. But when that protein isn't working, we can't do that process quite as well. And it goes into this other pathway where MEK is that leads to more cell growth and more cell survival. So MEK is just one of the enzymes there that is leading to cell growth, but it's the one where we found a lot of efficacy in blocking. So we talked a little bit about MEK inhibitor toxicity, right? So it's not like these medicines are without side effects. And those side effects actually vary depending on a patient's age. So for instance, in a younger patient, you might see more like a mild rash or eczema or dry skin. You could see a little bit of the nail infections, but not as common. You might see lower tone, like a little more floppy, a little bit of weakness with this medicine. And even though still rare, you could see more of the eye damages to the back part of the eye called the retina. And then the question about, long-term effect on development is something obviously that we're looking at right now. There's not like a signal of that, but certainly because they haven't been around that long, it's something that we still need to investigate, especially when we're treating very young children. Whereas in an older patient, like an adolescent or young adult, you might see more of the acne rash. That's more common. You do see more of the skin, of the nail bed infections. You might see a little bit of weight gain, more tiredness. We hear that more from our patients, or stomach issues like diarrhea or decreased appetite. And so I'm going to come back to this slide, but I just wanted to introduce it to give a framework for what we're going to be talking about. So these are some of the MEK inhibitors that are currently in use. And specifically, I focused on plexiform neurofibromas and low-grade gliomas because this is some of the areas where we've made the most progress with these. We'll go back to the preparation, but that sometimes, like it was alluded to earlier, may help us choose one MEK inhibitor over another for a particular patient. And then this is sort of where they've been approved. With selumetinib and mirdametinib, I'm going to focus on first being the ones that are FDA approved for plexiform neurofibromas, but it's not like the others aren't being looked at for these same indications. So I'll start off by talking a little bit about NF1-related plexiform neurofibromas. These develop in about 50% of patients with NF1, and they're typically congenital or manifest early in childhood. So you're born with them. You may not notice them right away, but they often manifest early in childhood. And they can be very infiltrative, meaning they can involve several nerves. Most often we see them in the arms or legs, sometimes in the trunk. And some of the ways that they can cause symptoms are they can kind of put pressure on some of the major breathing ducts. They can cause a lot of pain. If they're more superficial, they can cause disfigurement, and they can sometimes lead to motor dysfunction, things like weakness or difficulties with walking or using a limb. While they are benign tumors, the plexiform neurofibromas themselves, there is a risk of some of these to progress to a more aggressive tumor. And sometimes that's sort of a spectrum. They go into what's called an atypical neurofibroma, and then they can evolve into something called a malignant peripheral nerve sheath tumor, or MPNST. And so how do we manage them? And I think someone asked this question, well, how do you decide when you want to treat a plexiform neurofibroma? And that's really sort of the art of medicine. That's what we as clinicians, really a lot of our role is deciding, well, when do we treat and who do we treat? So we might consider observation, because not all patients with NF and plexiform neurofibromas require treatment. Most stable tumors, meaning tumors that aren't growing, don't cause morbidity or symptoms, and they may not ever progress or cause symptoms. And so with those cases where we feel like maybe let's just watch, let's observe for now, managing them really involves regular monitoring, coming for visits, doing an exam, checking for symptoms, and sometimes imaging to see if they're growing over a period of time. And then in some cases, we do decide to treat. And in those cases, our goal is to improve or prevent symptoms related to this plexiform neurofibroma. And so we often consider treatment in patients where they either have symptoms related to their plexiform, or we think they're likely to develop symptoms soon based on the trajectory of growth or kind of how they're presenting with their exam. And so intertwined considerations are, well, these are factors that may push us one way or the other. So how old is the patient may push us towards treatment or towards observation, how quickly or not the plexiform is growing, whether or not they have symptoms or symptoms that we think are likely to develop from it, what location it's in, and how progressive, like how much is growing. Is it quick, or is it like a very slow growth as the patient themselves are growing? Because as you might expect, if a child is growing, their plexiform is kind of growing with them. So is it growing at the same rate, or is it growing more quickly than we would expect? And when we treat plexiforms, we think of two major avenues. We think of surgery or medical treatment. Surgery would be preferred if we can achieve a resection or a debulking, like taking out some of it, but not all of it, without a lot of side effects or issues. But we can only take out the full tumor in about 15% of the cases. It's not common that we can take out the whole tumor, because like I said, it involves a lot of nerves in the body, maybe close to other structures that are important. And we know that if in those plexiforms where we don't take the whole plexiform, we only take a piece of it out, partial or subtotal, some of them regrow. Less than half, but still a good portion can regrow. And in a small subset, when we do decide to pursue surgery, there can be symptoms that develop that are long-term or permanent. And so we definitely take that with careful consideration, and we work with general surgeons and plastic surgeons at our institution to make that decision about, is surgery the right approach for this particular plexiform? And then there are other patients where we think, well, if we've decided to treat, let's say we think this needs to be treated, well, should we choose the medical route? And that medical route really is these targeted treatments, with the MEK inhibitors being the most common one we would choose. And that might be preferred if there's contraindications, meaning reasons why we shouldn't do surgery. But we need to consider things as logistics. Is a patient willing to come to clinic for labs and checkups and heart exams, all these different things that we need to monitor? Side effects. If you're an adolescent or teenager, you might not be willing to take the risk of acne for your plexiform. Maybe it's not you'd rather deal with pain than with acne. And so we have to kind of have that chat. The formulations, how can you take the medicine? And we're very fortunate that now we have different formulations available for patients who can't swallow pills. Adherence, so taking, right? You have to take a medicine daily, twice daily, every day for most of these. And so are you willing to do that? And then the long-term safety, like I said, with the younger kids and effect on development, those kind of things. So this is kind of, I think Courtney alluded to this earlier, but this is some of the monitoring that we might do for a patient that we start on a MEK inhibitor, right? So monthly visits with us with monthly blood work where we check the blood counts, we check the thyroid function, we check liver tests and pancreas tests, we check muscle enzymes. We have less often eye exams, about every 3 to 4 months, and then less often heart exams, the echocardiogram, which is a sonogram of the heart, and the EKG, which is looking at their heart rhythm. And then the MRIs we usually do every 4 months. I forgot to include that here, but that's another part of kind of how we monitor things, not just the exam. But these are quite frequent and burdensome to some people, and so they might not choose to go on these medicines. That being said, a lot of patients, we do all this, but they tolerate the medicines quite well. And so it's not that just because we're doing this means you're going to have one of these side effects. It's just we want to be diligent and vigilant, and we want to watch out for them and manage them early if we see something that's not right, a symptom that you're having or something like that. So I'm going to move on to some of the MEK inhibitors for plexiform neurofibromas. And so starting with selumetinib or closoleugo, because this was the first FDA approval. This was a sprint trial. It looked at children specifically with symptomatic inoperable plexiform neurofibromas. You might recognize this picture from earlier. It was a phase 2 open label study, and it looked at the volume, so how big the tumors were, but also the symptoms. So we talked about how sometimes you might get an effect on the symptoms before you get an effect on the size. But the symptoms may include pain, how well you're moving, what's your quality of life. And most children had durable, meaning like long-term shrinkage of the tumors and symptom improvement. So that was a big win for us in the NF community. And that led to the FDA approval of selumetinib in April 10, 2020 for children 2 years and older. This was not yet approved by the FDA for adults with NF1 and symptomatic inoperable plexiform neurofibromas. This is the dosing. It's 25 milligrams per meter square. It's given twice daily. The cycles are 28 days, and it's continuous, meaning you end those 28 days, you go on to your next cycle. So there's not a break for this one. And right now it's available in 10 and 25 milligram tablets, but there is a dispersible tablet that's not yet approved that they're working on. I said that last talk. It's still not, not out, but we're hoping. Someone had asked earlier, well, what about adults? Selumetinib is being looked at in an ongoing trial for adults with NF1 related plexiform neurofibromas. And there was some prelim data that was published back in 2020, and it was promising. So 69% achieved a partial response, and the time to response was around 11 months in that prelim data. And pain, importantly, scores significantly improved. Right, there are toxicities or side effects from the medicine, but they were pretty much the common side effects that we expect from MEK inhibitors. The liver enzymes in some patients were elevated, rash, or the pancreas, one of our other organ enzymes, were elevated. And these are things that sometimes we can manage by reducing the dose or doing a break in the medicine, those kind of things. And then more recently, we were also lucky that mirdametinib or Gomekli with the renewed trial has led to now our second FDA approval. So this trial looked at mirdametinib in children and adults with inoperable plexiform neurofibromas, again, a phase 2 open label study. And in this trial, they saw about 52% of children and 41% of adults saw their plexiform shrink by at least 20%. That's sort of the cutoff we use. That's a standard that's been established, that 20%. So some may have seen it shrink less than that. That's not included in this percent. About half of them saw results after about 4 months, and most saw results within about a year. And these are some of the tables, just looking, if you look at the blue and red lines, the blue line is treated with mirdametinib, and the red line are left untreated. So there's natural history studies that have looked previously at like how plexiforms would go over time, and they did much better on the mirdametinib, especially there was a bigger gap if you were noticing that they were progressing at the time of treatment. And so mirdametinib was approved in February 2025, very recently, again, for children and adults. It's also twice daily dosing and 28-day cycles, but this is a 3 weeks on, 1 week off kind of treatment. So there is a week break in there. And again, like we had mentioned before, the other great news is that it's available as great flavored tablets that you dissolve in water for a liquid suspension. It's also available in capsules for those who prefer to swallow, but now we have these two formulations. Other MEK inhibitors that are being looked at with plexiforms. So trametinib or Mekinist, the TRAIN study has looked at trametinib in adults with inoperable plexiforms related to their NF in a phase 2 trial. Again, looking at volume and symptoms. In this one, so far, what they saw is 37% discontinued in the first year, either due to toxicity or symptoms that were progressing, but about 48% responded within that first year of treatment, and 52% had stable disease. And the pain rating scale also decreased at 1 year follow-up. So we are seeing some signs of efficacy for trametinib in adults. And then binimetinib or MEK is being looked at in children and adults with plexiforms and NF1. This is an ongoing study, but there is some preliminary data that's showing about 70% partial response in children and about 60% partial response in adults. Again, grade 3 toxicities are some of the ones that we would expect, as I had talked about, like the common side effects of MEK inhibitors. So it's not like we're seeing a very varied toxicity from these different MEK inhibitors. But like was alluded to earlier, some patients might tolerate one MEK inhibitor better than another. And so just because you see side effects on one doesn't mean we can't try a different MEK inhibitor in the future if we wanted to. I'm going to shift gears a little bit just to another common tumor in NF1, because this is another one where the MEK inhibitors have shown a lot of promise, and that's low-grade gliomas. So low-grade gliomas are one of the most common central nervous system tumors in children with NF1. When we say low-grade, we mean like slow-growing, benign. They're not aggressive, growing quickly. That being said, it doesn't mean that can't cause symptoms. And one of the more common low-grade gliomas within that category that we see in NF1 are the optic pathway gliomas, those affecting the nerve to the eye. And that can occur in about 15% of children younger than 6 years of age with NF1. They can occur anywhere along the optic pathway. So the optic pathway includes right behind the eye, we have a nerve. Then it kind of crosses together and goes to the back part of the brain and even further back in the brain. So it's not just that nerve, but all the pathway that kind of helps us see. But many children with NF1 have optic pathway gliomas and they have normal vision. Only a small portion develop symptoms. And what are those symptoms? The most common is vision loss, but sometimes something we call proptosis, or the eye kind of bulging out a little bit, can be another symptom. And so how do we treat these? Well, if possible, we observe for some time with close monitoring. If the child doesn't have vision loss, let's say we image them for headaches, and we found that they have something on the MRI that looks like an optic pathway glioma. They see the eye doctor and their vision is normal. So we would observe that patient. Now, if we see vision loss, right now the standard of care is that we would treat that child with chemotherapy. And that is usually a combination of carboplatin and vincristine. That's chemotherapy for low-grade glioma. Sometimes that can be carboplatin monthly or vinblastine weekly. So there are different iterations of low-grade chemotherapy, but that would be kind of our first line. But now there are several studies evaluating the use of MEK inhibitors in these patients, either, if they've been treated with chemotherapy and they progress, but also up front, when you first diagnose a patient and you feel like they need treatment, might you use a MEK inhibitor? Important to note that, starting treatment doesn't always lead to vision coming back. It helps prevent further vision loss, but in some patients, you do get some vision back. And then just other considerations like surgery or radiation surgery, you worry about, well, then complete loss of vision if you take out that optic nerve. And then radiation with NF1, we worry about other tumors related to the radiation, or there's a condition that affects the arteries in the brain of children or adults with NF1 called moya, and the radiation can make that worse, can cause more narrowing of those arteries. So we often avoid it for that reason. So now going to the MEK inhibitors in these. So one of the studies looked at selumetinib in children with either BRAF aberrant. BRAF is one of the common areas that can be mutated in low-grade gliomas, or NF1 associated. And this was for recurrent, refractory, or progressive. That means children that were treated with the chemotherapy first, and now their tumor is becoming symptomatic again or growing. And so this was a phase 2 trial looking at these recurrent or progressive low-grade gliomas, and they found that selumetinib was effective in those that were NF1 related or had that BRAF mutation. And so in these groups, selumetinib or MEK inhibitors, in the future other MEK inhibitors, may be an alternative to chemotherapy. And so the next step, logical step in thinking is, well, what about from the get-go, could we use a MEK inhibitor? And that's a current phase 3 study that's looking at selumetinib upfront in these patients. So it's a head-to-head comparison of selumetinib versus carboplatin and vincristine in patients with NF1 and low-grade glioma. These are newly diagnosed, not treated yet. And the questions are, does selumetinib work as well as standard chemotherapy? And is it potentially better at preserving vision or improving vision in patients with NF1 and optic pathway gliomas? There's not an answer yet. There's other MEK inhibitors that are being looked at in this population. So selumetinib is not the only one. Mirdametinib is being looked at in children and young adults. And the prelim data is promising because patients, around 74% of patients stayed on or completed treatment, and 63% achieved an objective response. And then Benitez is being looked at in that recurrent progressive category after upfront therapy. And that trial actually includes low-grade gliomas and some other tumors, so could potentially be looking at plexiform neurofibromas and NF1. I don't know like how many patients they'll accrue or be able to include in that trial. So back to the summary slide, and then I promise I'll be done. These are some of the different MEK inhibitors that are being looked at in NF1 and these different kinds of tumors. The FDA approvals are for selumetinib in children and mirdametinib in children and adults with plexiform neurofibromas. Selumetinib is being used in patients with recurrent or progressive low-grade gliomas, but now being looked at as a possibility up front. Trametinib and Benitez are also being studied, but are not yet at the stage of FDA approvals. Thank you. And if you have time for questions related.